Good afternoon, everyone, and I'm here today at the 54th annual ICS meeting here in beautiful Madrid. For the live audience here today, thanks for coming, and for those joining us virtually, it's lovely to have you, and sorry you missed this beautiful city. We've had a fantastic conference so far, very busy, lots of registrants and attendees, and some really wonderful sessions, haven't we, with with the forums and the workshops and the scientific sessions, and so many different areas of educational opportunities. You can't visit all of them. I'm here today with my colleagues, and they both presented today at the scientific abstracts this morning, wasn't that? And I guess you had a full house, and lots of attendees and lots of questions answered. So over here on my left, I have Dr. Victoria Salmon from the University of Exeter. So welcome, Victoria. And I have Dr. Cristina Gallego-Gómez from the University of Castilla-La Mancha. So I'd like to welcome you both, and I hope you're enjoying the conference so far. Now that you've got your presentations done, hopefully you can relax a little more and enjoy some of the networking opportunities that we have at ICS and some of the other sessions. So, Victoria, I wonder, you had a very interesting abstract that you presented this morning. Can you tell us a little bit more about it, and for the audience that haven't seen from home, about your research?
Yes, thank you very much. So thank you for the opportunity to talk about this again. So this was presenting a piece of work that we've done in England, or in the United Kingdom, looking at the rollout or implementation of a training program for midwives to teach pelvic floor exercises during pregnancy in order to prevent urinary incontinence. So this was an opportunity to share some of the real world findings that we are seeing. So this was a training called Appeal that was developed through a research program, and we did do a pilot and feasibility trial. And after the trial in England, there was a policy change. So we've now got this introduction of perinatal pelvic health services across England. So therefore we couldn't do a definitive trial because we don't really now have a comparator, because all services are now supposed to train their staff. But whilst obviously policy is great and really encouraging, there's very little guidance on how to go about training the staff. So we were able to offer our training to UK-based antenatal care staff through these perinatal pelvic health services. So the abstract I presented this morning was the very early findings of what's happening now that people are being trained in the real world, if you like, rather than under control conditions. So I was sharing that we have delivered train the trainer sessions to pelvic health service leads, and those service leads are then delivering their training in their local services. And what we were able to do is gather some pre and post training confidence data for the staff going through the training, using the same questionnaires that we used as part of the process evaluation in the trial. And what we've seen was that those trainers are staff being trained. Those who returned the data showed that they're having the increase in confidence to ask about urinary incontinence, bring the topic up, talk about pelvic floor exercises, and refer on to specialists. So these, it was the same as we saw in the trial. So that was really encouraging to see that we were able to maintain those trial findings, that the staff confidence increased. What obviously we want to see next is whether that translates to them putting that training into practice. But it's only just, staff have been trained, and we're seeing some really positive outcomes. And what that means is it's potential to train non-specialist staff in routine care appointments to pick up earlier some maybe either symptoms, but also give women their basic instruction in pelvic floor exercises as a preventative measure. So the next steps will be to see whether that then translates into them implementing it well, and the outcomes, of course, for women. But
of course.
Initial findings are positive.
Oh, excellent. I mean, it's so important having pelvic floor exercises antenatally and not waiting until it's too late and starting postnatally. Now, with your research, with your study, was it just midwives that you trained, or was it like nurses, like nurse continence advisors, or just regular nurses?
Great question. So in the appeal pilot and feasibility trial, the intervention was designed with and for midwives. We did train some maternity support workers, as we call them in the United Kingdom, to deliver it as well. But it was primarily community midwives, who would be the people who would see women for their antenatal care. In the real world setting, they can train whoever they want in their services, and we have collected some data about who was coming through, and it is still predominantly midwives that were receiving the training in these health services because it's about antenatal care. They deliver most of that in the UK, but we've had obstetricians and other antenatal care staff receive the training. What we are also doing, though, is we've got a program of work where we are adapting the training for use in primary care, but that will be more of a life course approach, and my colleague Sarah Dean is presenting an abstract on that on Friday afternoon.
Oh, that would be really interesting to hear too. And how long does your training per se take? Is it like a given course that takes a certain time?
So when we developed the intervention, it was really important that this was something that was feasible for midwives and acceptable for midwives, and they are incredibly busy, work in incredibly pressured environments. So it's the training is 90 minutes, but we train them in a stepped approach to do a very brief intervention at each time point that they see the woman. So within their practice, the longest it might take is, say, 5 minutes of an appointment at the 16-week appointment, for example, in the UK, but otherwise it's a sort of 2 minutes each session, and that's really important to make it feasible and acceptable. It means it's brief and basic, but it's a really good start point for picking up symptoms early, referring them on early, but preventing them and getting women started on pelvic floor exercises.
Great work. Thank you for sharing.
Thank you.
And Cristina, I know you've done some wonderful research on postnatal depression in women postpartum with incontinence. Would you be able to tell us a little bit about your research and the outcomes?
Repeat.
Can you tell us about your research paper that you presented this morning?
Yes. Hemos realizado una revisión sistemática.
¿Quieres que te traduzca?
Yeah.
I can translate directly. Yes. Okay.
Sorry, we're just going to have a bit of translation here.
Sorry. She's talking that she has developed research. Sorry, that's it. Maybe like this. Thank you. It was it was a research. She has been reviewing some
de estudios longitudinales y estudios transversales. Cohort studies and cross-sectional studies para identificar en las mujeres en el periodo posparto si la incontinencia urinaria favorece la aparición de la depresión posparto.
Yeah, the goal was to research association between the postpartum urinary incontinence and depression, mental health. So it was a meta-analysis research.
And what were the outcomes of the research?
Y también si el tiempo, la duración del tiempo de posparto, if the time after delivery reduce o intensifica esta asociación.
And also the relationship between the length after delivery, the postpartum time, and urinary incontinence, if there is any relationship. And ¿cuáles fueron los resultados, Cristina?
Sí, nuestros estudios concluyeron que realmente la incontinencia urinaria sí que favorece la aparición de la depresión posparto. Pero en cambio, el tiempo de posparto no hemos encontrado evidencia de que aumente o disminuya esta unión.
And the conclusions, first the outcomes
la fuerza.
There is a relationship between postpartum and depression, after delivery, but there is no relationship about the time. So it doesn't matter how long it has passed after delivery. There is no statistically significance between these both.
Aunque sí que hemos
factors.
comprobado que es más frecuente que aparezca la depresión posparto unida a la incontinencia urinaria en las mujeres primíparas con una escala de Edimburgo de valores mayores o iguales a 13.
Okay, so however, it's more frequent. It's higher the rates. It's more frequent postpartum.
Sí.
Yeah, the
La
postpartum
incontinencia,
depression.
sí. En mujeres primigestas o primíparas que ya tienen una escala de Edimburgo mayor o igual a 13 y que la depresión se continúe después del posparto.
However, the pressure and the urinary incontinence was stronger. They have a stronger relationship in case of a woman with a scale, Edinburgh scale, higher than 3. What's the score?
13.
13, sorry. Higher of 13, that score.
Y en cambio es menos frecuente en mujeres multíparas.
It's more frequent in primíparas comparing to multíparas. So that was.
And can you ask Cristina
Yes,
if did she do any research around women that had done pelvic floor exercises antenatally and the incidence related to incontinence and postpartum depression? Was there any correlation between pelvic floor exercises? If they'd done them or didn't do them?
Que si el ejercicio...
Sí, se ha estudiado si las mujeres antes, durante el embarazo, han hecho ejercicio y si eso pudiera afectar en el posparto.
Realmente los estudios han sido como muy diversos y una de las limitaciones del estudio es básicamente que no todos han considerado si había problemas, si hacían ejercicio o no, si tenían o no problemas sexuales, el nivel económico, el cansancio, todo eso. Las odds ratio casi todas eran crudas y no estaban ajustadas a estos valores, y es una limitación. No consideraban el ejercicio.
Yeah, she's talking about some limitations during the research, and due to the high heterogeneity of the different studies, there are a lot of questions just to be researched because it depends of the studies. There was high heterogeneity. So there are questions about if the women were doing exercises have not been analyzed because it was not possible. Some limitations also was about fatigue during pregnancy,
income level, sexual
the economical
problems.
level, the sexual dysfunctions. So it was not possible to analyze these factors because the high heterogeneity. That's it.
Muy
Very
pocos
interesting.
artículos, sí.
Very, very interesting work, because I'm just seeing the two documents, the two abstracts, and both of your researches kind of mesh together, that if we can do antenatal exercises and prevent incontinence postnatally, then hopefully we'll cut back on the depression. And you probably saw that in your practices.
Yes, I mean we
too.
weren't looking for depression. Our outcome was stress urinary incontinence 3 months after giving birth. But of course, if there is an association, then it's another reason to promote antenatal pelvic floor exercises. But for all women, means doing it through an antenatal care pathway.
Yeah.
Relying on just seeing specialists is not really going to reach as many people.
Yeah, absolutely. Having the follow-up with the midwives and checking that they're doing their pelvic floor exercises, because maintenance is key, isn't it? Are there any other key messages that you would like to give to the audience, or before we take questions? Or
Que si vamos a seguir haciendo...
¿Alguna otra conclusión, algún otro detalle que quieras comentar, algún dato importante? Que no había, por ejemplo, puedes comentar lo del tipo de incontinencia, a lo mejor.
Sí, otra de las limitaciones que hemos encontrado es que, aunque se sabe por estudios previos que la incontinencia urinaria de esfuerzo es la más común en el posparto, otra limitación fue que no hemos encontrado el tipo de incontinencia en nuestros estudios. Solamente uno de los estudios incluidos hablaban de incontinencia urinaria de esfuerzo, en cambio el resto era como incontinencia urinaria en general.
Yeah, she would like to highlight that the association between depression, postpartum depression, and urinary incontinence. It was in general the studies they didn't discriminate between urinary incontinence, stress urinary incontinence, and urge urinary incontinence. That's quite important.
Y también la conclusión es que ambos problemas, tanto la incontinencia urinaria como la depresión postparto, son tratables, y un abordaje precoz pues mejoraría mucho la calidad de vida de estas mujeres.
Yeah, just to remark the clinical relevance of the results, to implement maybe some prevention and some programs to
Ambas
avoid
son tratables, claro, las dos.
both urinary incontinence and depression postpartum.
Thank you very much. Any questions, please? She's going to translate a question for you.
Oh, okay. So I want to ask, did you see that the depression is fading away with improvement of the incontinence? Did you see any connection in resolving these symptoms together?
The long-term results, you mean?
Whatever it disappears, whatever it improves, not disappear.
Sí, le gustaría saber si hay una relación en donde, si al mejorar la incontinencia urinaria, mejoraba la depresión. Si se veía...
Es lo que hemos dicho, que se ha visto que los cuadros de depresión duraban más las mujeres primíparas, que además tenían coincidía que tenían una depresión como más alta en la escala de Edimburgo. Y en cambio los cuadros de depresión sí que se resolvían con más frecuencia en las multíparas, que tenían además una escala de depresión de 10. Pero tampoco hemos visto, no hemos valorado estudios después del año de posparto. Nos hemos quedado en el año posparto, un año.
Sorry, I'm going to translate. The result was measured during 1 year. That was a follow-up. And in case of multiparas, the depression was improving higher and faster comparing to primiparas. In primiparas, the levels of depression was staying high levels. So that was one difference, but only that idea, only that point.
Y también que hemos visto que la media de personas que padecen depresión posparto a causa de la incontinencia urinaria en el periodo posparto es del 45%. Eso lo hemos dicho también esta mañana, pero...
¿45%?
45% en la media de las mujeres en el periodo posparto que tienen depresión a causa de la incontinencia urinaria en nuestros estudios.
Claro, sí, pero bueno, era por la relación a largo plazo. Sí.
Vale, a largo plazo solamente hemos visto eso. Dile que en caso de estudios que hacían valoraciones posteriores al año, siempre hemos cogido los de antes del año.
Yeah, 1 year was the follow-up. So we don't know further after this period of time.
Please.
I'm sorry.
Thank you. I have one question for each of you. Perhaps I will start with this theme. Te voy a poner la cuestión primero y después la otra. The studies that you have analyzed, do they control the bias from the support the women have, the problems with breastfeeding? Is that was controlled and not mixed with the incontinence problems and the program they were doing? Si los estudios que has ponido en la revisión, si ha sido el control de los soportes de la familia, de la madre, de los...
Sí, te he entendido en inglés incluso. Entiendo mejor que hablo. Pues Sandra, sí que es cierto, como hemos comentado, que los estudios son muy heterogéneos y aunque algunos sí que han tenido en cuenta esos factores de los que hablas, muchos otros no. Como ya he comentado.
Yeah, so the biggest problem was the heterogeneity. So some studies are researching some factors like this, but not all of them. So it's impossible to that was a limitation, you know. It was not possible to analyze in all the cases.
And you had another question for Victoria. Go ahead.
And for the program, how many weeks did you did the program, and how many time does the sessions have? How long the program, and how long is one session?
Thank you. So this training program for midwives isn't an ongoing supervised pelvic floor muscle education program. It teaches midwives how to teach a basic pelvic floor contraction, how to establish a start point for the number of repetitions and holds, and for the women to go away and practice that themselves. So this is preventative. So they go away and they come back for their next routine antenatal appointment, and the midwives are taught to ask them, how are you getting on with it? Any difficulties? How are you leaking? Do you leak at all when you cough and sneeze? And do you want me to check you doing a contraction again? And they go away. So the midwives get trained in a 90-minute training session for them. The rest is delivered in routine antenatal appointments. So there is no specific pelvic floor muscle exercise sessions. It's embedded within the routine pathway. Now, if they've got a woman who comes back the next session and said, well, I'm really struggling and actually I am leaking more or it's getting worse, they then also know within their local service how to refer on to a specialist. So this is training non-specialists to provide a prevention message on a population-based approach and refer on when needed. So it's that sort of basic level. It's not a sort of supervised ongoing program. It's supervised in so much as there's someone checking back in, but they're not doing more than that. So it's a home program for the women to do or not do if they don't engage, but it's down to them, and it's referral on if there are problems.
It's a literacy program and an educational program.
Sorry, I can't hear the question.
It's an educational program, or taking higher literacy from women from the pelvic floor.
Essentially, they do teach
awareness.
Yeah, awareness, raising the topic, because what we found in the preliminary research when we were developing it is women aren't going to raise the topic, or they think it's normal because the societal kind of message is, oh, this is just something that happens when you're pregnant. So it's teaching midwives to ask about it and say, actually, this is common, it's not normal, there are things you can do, here's some information, go away and look at it. Next time we're going to talk about it in some more detail. And next time, let's give it a go, let's do a contraction here, this is how you might squeeze and lift, and And the midwives have scripts they can use when they're starting out, so that they feel confident, and the women go away and do it at home. But yes, so it's education and a bit of practice, but it's not a full supervised program.
Well, thank you so much to both of you for being here at the Live Lounge today and sharing all your wealth of experience and knowledge, and good luck with the rest of the meeting and with your research moving forward. Thank you so much.
Thank you.
Thanks for having me.
Take care.
Thank you.